Indian Academy of Cerebral Palsy webinars, Learning Without Barriers, under the leadership of Dr. Mallikarjun and Dr. Shaktidas. We present webinar on ICF by Dr. Mellisa Selb and Dr. Suzie Noten. Moderator for the webinar today will be Dr. Meenakshi Girish. ICP welcomes you.
I invite Dr. Mallikarjun.
On behalf of
already introduced her. All I can say about Mellisa is that, first of all, I'm so thankful that when we first wrote to her, inviting her to give a talk, there was a very instant response. She was eager to share whatever she knows, and which means everything she knows about ICF with as many people as possible. So thank you, Mellisa, for that. Mellisa Selb is deeply involved with this topic, International Classification of Functioning, Health and Disability, which is part of WHO definition of health and classification. Mellisa has been involved in designing the components and the categories of ICF. Whatever paper literature search you do and you look for ICF, you rarely find a paper without Mellisa's name as one of the authors. So we are all very privileged to hear about and learn about ICF directly from the person who actually led from the front in all research projects related to ICF. And she is, as the slide says, she is the research coordinator representing WHO, if I'm not wrong. Can I have the next slide, Jasmine? Okay, there is, I will introduce Suzie Noten at the time when when it's her turn to present. But it's my pleasure to hand over the mic now, hand over the screen to Mellisa to start her lecture.
The International Classification of Functioning, Disability and Health. Oh, it's going too fast. And also the derivative of ICF core sets. And I am the coordinator of the ICF research branch, which used to be a partner of the German WHO Collaborating Center for the Family of International Classifications. But since last year, we're independent of the Collaborating Center, but we're still working very closely with other collaborating centers all over the world and also with WHO. So I do not work for WHO, and I've been involved the last 11 years with ICF work all over the world, and our organization, the ICF Research Branch, is coordinating with different organizations. Here you see the members of the ICF Research Branch Steering Committee. It's headed by our director, Professor Gerold Stucki. And in my institute, which is the Swiss Paraplegic Research, my colleague, Professor Jerome Bickenbach, is also one of the steering committee members. And in Germany, we have two people from the steering committee, Dr. Michaela Köhnen, who's at the Ludwig-Maximilians University in Munich, and Professor Lian Simon at the Medical School Hamburg. And in Switzerland, also Professor Judith Hollweg, and her specialty is children and youth. So as Meenakshi mentioned, the ICF is one of WHO's reference classifications, along with the International Classification of Diseases, or ICD, and currently it's in its 11th revision. And our group is also working very closely with WHO on ICD. It also, one of the other WHO classifications is the International Classifications of Health Interventions, or ICHI, which should be endorsed this year by the World Health Assembly in Geneva. So the ICF goes from a purely biomedical model, which is represented by the ICD, to a biopsychosocial model. So it's going from looking at the evaluation of disease consequences solely from a biomedical perspective to a health perspective that is based on a biopsychosocial model, which includes not only the health condition, but also functioning, which comprises body functions and structures, activities and participation, and environmental factors, as well as personal factors. Now, for you to, is a dynamic interaction between these different entities or different ICF components. So if you have a change in one component, you have potentially a modification in one other component. So in order to explain to you this whole biopsychosocial model, I've asked Dr. Deepti Shanbhag, who published on your website, on the Indian Academy of CP website, under the rubric of inspiring stories. So I asked her if I can use her story that she told about her son Rishi to explain to you all these different components of the ICF. So as the model shows, the health condition is sort of the starting point. It generally is used to describe, report, and document the functioning of persons with a health condition. A health condition in the ICF is considered the umbrella term for disease, disorder, and injury, as well as trauma, but it can also include such things as aging, stress, strangely enough, pregnancy, or a genetic predisposition. And health conditions are coded using the ICD. So if we take a look at the example of Rishi, Deepti stated, my son Rishikesh, sorry for the pronunciation, was diagnosed to have cerebral palsy with diplegia and speech impairment. He was born at 37 weeks and had respiratory distress due to immature lungs. There was a delay in referral by at least 8 hours, which was possibly the time he suffered brain hypoxia. So based on this description, and also clearly says that that Rishi was diagnosed with cerebral palsy with diplegia. The health condition would be spastic diplegic cerebral palsy based on the current ICD version, ICD-11, and has a code of HD20.11. By the way, you can, and people can ask me questions if there's something's not very clear or if I'm speaking too quickly. So please just tell me. When we look at the ICF biopsychosocial model component of body functions and structures, the ICF defines body functions as physiological functions of the body, which also includes psychological functions or mental functions. The body structures are logically the parts of the body, such as organs, limbs, and their components. And if we're talking about impairments in body functions and structures, we're talking about a significant loss or a deviation in those areas. So if we take a look at, again, Rishi's situation, Deepti writes, we have always had a therapist come home and do all exercises to my son from the age of 8 months. So he did not have any contractures, and his muscles his muscle was well toned. He was also diagnosed to have a speech impairment as a baby, and right now he still speaks only a few words. So if we're looking at body functions and structures, we're talking about articulation function problems, as well as no contractures and good muscle tone. When we look at the components of activities and participation, activity is defined in the ICF as the execution of a task or action by an individual. So what the person does, basically what he or she can do on a daily basis, and participation is the person's involvement in a life situation in society. So we're looking at limitations or restrictions in activity and participation. Activity limitations are the difficulties a person may have in execution of a task or doing some sort of action in daily life. And we talk about participation restrictions when the person has a problem in getting involved in everyday life situations, in getting involved in the community or in society. When we look at Rishi's situation, Deepti writes, then I put him in a special school which really was a turning point for Rishi. He now has a teacher who shows him a lot of pictures and has friends who he could relate to. He still speaks only a few words, but he expresses certain things through signals. He expresses, for example, sorry by pulling both of his ears. He loves to listen to Kannada film songs, and he is absolutely toilet trained. So if we're looking at the biopsychosocial model, these things come up. He speaks a few words, communicates through nonverbal messages. He's independent in toileting, at least based on the description. He has relationships with friends, and he goes to school and listens in his free time, his recreation and leisure, to Kannada songs. So let's move on to environmental factors. Environmental factors are the physical, social, and attitudinal environment in which a person lives and conducts his or her life. Environmental factors are what we call contextual factors. They are basically external to the individual. So like body functions and structures and activities of participation are what the person does. Environmental factors are outside or external to the person. So it's everything outside of the person. Environmental factors can have a positive or negative influence on the individual's functioning. In Hiri's case, Deepti writes, we have an in-house caregiver who stays with us and looks after my son all the time. I was fortunate enough to get good, trustworthy ladies who wholeheartedly devoted their time to Rishi. Then I put him in a special school, which really was a turning point in Hiri's life. He now has a teacher who shows him a lot of pictures, and the school provides him a platform for opening up his mind. He has a caregiver who he really bosses around. So when we look at environmental factors, that means he has supportive caregivers. And based on the whole description of the story, it seems to me that his parents, Deepti, and her husband are very supportive of Rishi in his daily life. And he's got a supportive teacher, or perhaps more than just one teacher, and he has a special school that supports him in his learning and his daily life. In terms of personal factors, they are the particular background of an individual's life living and comprises of different things such as gender, race, age, his lifestyle, habits, coping style, social background. And unfortunately, in the ICF, this is basically the only description. It's not expanded any further. In terms of Rishi, Deepti says, my son Rishikesh is 18 years old. He loves toys, cars, especially the brand Hot Wheels, and expects me to bring a new one every time I travel. He loves food and wants it to be tasty, so he will not eat food if the food does not live up to his expectations. So reading this, I decided that the personal factors with regards to Rishi is that he's 18 years old, he's male, he loves tasty food and loves collecting Hot Wheels. So these are the descriptions of the ICF components, or the components of the biopsychosocial model. Later on, I will show you what the corresponding codes are with regards to this whole model that I have showed you and explained to you. But in order to do that, you have to understand the structure and codes of the ICF. So the ICF is a classification which is made up of different categories or codes, and it's built up in a hierarchical fashion. The ICF has two major parts: functioning and disability, which is made up of components: body functions and structures, activities and participation. And as I mentioned before, the other part are contextual factors, which is made up of environmental factors and personal factors. When we look at the body functions, when we look at the body functions and structures, they are two different components: body functions and body structures, and activities of participation is separately. So the ICF hierarchy is made up of chapters. You see here B1 to 8, S1 to S8, D1 into D9, E1 to E5. So the chapters, for example, in environmental factors, there are 5 chapters. That's why you see E1 to E5. And personal factors do not have any codes yet in the ICF. And WHO is not planning to have personal factor codes in the ICF. The ICF is currently being revised, or not revised, but updated every year. And also WHO is rethinking the ICF, whether or not personal factors should be included as part of the ICF. So that's why they haven't put codes to it yet. So the ICF hierarchy starts with chapters, then it proceeds to what we call second level classification or second level categories. Here you see, if you look at the body functions, we have B110 to B899. That's the second level classification. And then the second level classification can be subdivided into third level categories. Here we'll see in body functions B110 0 to B789. And the third level classification categories can be further subdivided, if available, to fourth level categories. In the case of body functions, again, the third level classification can be divided to B114 20 to B510 59. You notice that not all third level codes or categories can be subdivided to fourth level categories. Because at this point in time, there are only fourth level categories in the body functions and structures. So as I mentioned before, here are the exact categories that I've used to represent the functioning and the contextual factors of Hirishi, as I've explained before. So for an example, if we look at body functions and structures, the articulation function problems that Hirishi has, or the speech impairment, can be represented by B320 articulation functions. And his mother says he has no muscle tone function problems, no contractures. So it can be represented with B735 muscle tone functions, as well as B740 if he were to have problems there. But you can also represent it with these categories even if he doesn't have any problems. The same thing with the the activities of participation and the environmental factors. There are codes for that as well. So the hierarchical structure of the ICF, as I mentioned, is broken up in between chapters and different levels. Here I give you another example, which is not relevant, at least not based on the description of Rishi's life. Chapter, which is in this case, B2, sensory functions of pain. That can be broken up into second level. In this case, it would be B280, sensation of pain. The second level can be further broken up into third level categories. In this case, B280-01, pain and body parts. And then you could go through the individual body parts or general body parts under the fourth level. B280 10, B280, 11, etc., in this case, to identify the different body parts. And as you go from the chapter level to the fourth level, the detail of the actual category increases. The ICF also offers a scoring or a scaling system called ICF qualifiers. What you see here are the generic ICF qualifiers, and it goes from 0 to no problem to 4 complete problem. If there are any questions, it seems like there are some questions that come up in the chat. Please. I'm just looking at the chats. Okay, there are no questions so far, so I'll proceed. Please just stop if there are any questions.
Mellisa, there is a question.
Yes, please.
He's diagnosed as spastic diplegic CP, and mother says no tone issue. So which one we will score?
In terms of the ICD-11, are you talking about the ICD-11?
ICF level.
In terms of ICF itself, let me go back to, because the spastic diplegia CP is, let me just go to the actual slide. Oops. So in terms of the actual diagnosis, as you can see here, this slide, it's diagnosed with 8D20.11, which is spastic diplegic cerebral palsy. That's the actual ICD code. So diagnoses, the disease or the disorder, are coded with the ICD. The ICF does not code diagnoses, but rather functioning. So we separate functioning from the diagnosis or the disease itself through this biopsychosocial model. That's the differentiation between the diagnosis, which is with the coded with the ICD, and the codes of the ICF. For example, the muscle tone functions can be coded with B735 muscle tone functions, or in combination with B740 muscle endurance functions. It depends on what you want to focus on. So is that clarified?
So you said that if there is no problem in the muscle tone, even then we can mention it, or there has to be a problem for us to mention it?
No, you can mention it by using the qualifiers. As you see here, the qualifiers include also no problem. Sometimes it's helpful to know that there is not a problem in a particular area of functioning. So that's why we can indicate it with no problem, with 0.0. If there is a problem, and depending on the level of the problem, you can indicate it with a 1, 2, 3, or 4, signaling a mild, moderate, severe, or complete problem. But this is just one of several scales that you can use to rate an ICF category. This is just one that was presented or proposed by WHO. But you are not required to use this, and I know different users of ICF categories use some sort of qualifiers, other scaling systems. And then we have 8 and 9, which can be used for different situations if the actual category is not specified, or if it's not applicable. For example, for Rishi, who's a young man, menstruation functions are not applicable for him. And then there are also other qualifiers for environmental factors. Because I said it can have a positive or a negative influence on functioning. So that's why there are also qualifiers that represent the positive, what we call facilitators, or the negative influence on functioning, called barriers. But the scaling itself, the generic scaling, is still going from 0 to 4 to represent 0, no barrier, 1 to 4 as mild, moderate, severe, complete barrier, or if it's a positive influence. For example, we're talking about supportive parents or supportive teacher, we can indicate that with mild, moderate, substantial, complete facilitator. Because if you're doing goal setting, you might, that would be important to know as well if you want to increase the facilitative aspect of a contextual factor. Can I go on?
Yeah, Mellisa will take all the questions at the end. So
Okay, very good. Yeah. So if you want to learn more about the actual ICF, about qualifiers, about the different components, you can go to the ICF e-learning tool. Also, different people, different organizations offer ICF workshops. The ICF research branch, for example, in Switzerland, for us, we also offer more detailed ICF workshops. The next one will be held at the end of March. Virtually. So you can go to the ICF Research Branch website if you want to check that out. But anyway, this is free. The ICF e-learning tool is a product from WHO, and this is the link to it. And this ICF e-learning tool comprises of different chapters, looking at the need for the ICF, aims of the ICF, uses of the ICF, as well as the ICF model. You can go through the different modules, and at the end there is a quiz or with different types of questions, and you can begin the quiz again or begin the learning process again if something's not clear. So you can go through that. So as I mentioned, the biopsychosocial model contains various ICF components. And the ICF has over 1,400 categories. And because it's so extensive, that has so many categories, as you can see here, the WHO and the ICF research branch decided to collaborate to create what we call ICF core sets. Because using 1,424 categories in the ICF, and the ICF children and youth version is even more, over 1,600 categories. To use that classification on an everyday basis is impractical. So we collaborated. The ICF research branch collaborated with WHO and other partner organizations to create ICF core sets. We created the process to develop ICF core sets. What are ICF core sets? ICF core sets are our selection of the whole ICF into two different types of core sets. We have the comprehensive ICF core set, which is a larger set. It could contain from 75 to over 100 categories, and from the comprehensive version of the ICF core set, we derive the brief ICF core set because it's derived from the comprehensive set. Depending on how many categories are included in the comprehensive set, the brief set will have also different amounts of categories. And we also develop other ICF sets called ICF generic 6 or 7 set or ICF generic 30 sets. These are generic because the ICF core sets were developed for specific health conditions or different situations. And the generic sets are meant to be used irrespective of health condition. So one is the first one, the minimal set, which contains 7 ICF categories, and the generic 30 set, or used to be called rehabilitation set or disability set, it contains 30 categories. So the ICF core sets are aiming to make the ICF more practical for clinical work as well as for research and other applications. And it also supports the standardization of assessment and reporting of function of persons with any health condition. I'd like to now introduce to you how ICF core sets are developed, because with this you'll understand the next presentations on the ICF core sets for children and youth with cerebral palsy, as well as the presentation from Suzie. So the ICF core set process comprises of a preparatory phase, which looks at different perspectives, the clinical perspective, researcher's perspective, patient's perspective, and the health professionals or the expert's perspective in general. And to cover those different perspectives, 4 different studies are conducted. An empirical multi-center study, which is usually done in a clinical setting, a hospital or a clinic, systematic literature review, a qualitative study, and an expert survey, which is usually done online. Then there's the second phase. All the results of the preparatory studies are provided as so-called evidence, and the starting point for the International ICF Consensus Conference, which aims to develop the first version of the ICF core sets. I say first version because depending on the validation studies, the testing and validation phase, it may change slightly or extensively. And the general time frame for that is between 2 and 3 years. If you're interested in understanding more about the development process, you can read the publication that I referenced below. Now I'm going to go through all the different preparatory phases and a little bit on the consensus conference phase. So the preparatory phase comprises of 4 studies. One study is the qualitative study, which comprises of either focus groups and or individual interviews. We say that focus groups are probably better to produce very rich data, but individual interviews are also helpful if, for example, the population requires that individual interviews are done, and it's possibly better in cases, for example, the one for sleep. It was important that we had conducted interviews because people tended to sleep, had sleeping problems. So during the focus group, they tended to fall asleep. So the individual interviews were also helpful. So the qualitative study interviews and focus groups were transcribed, and the transcribed texts were linked using an established linking methodology to map up or identify the respective ICF categories that represent those concepts that were transcribed. So after the linking was done, we do a frequency analysis, and you conduct the qualitative studies or the focus groups and individual interviews until saturation, which means no new codes were revealed after the linking was done. And the identified ICF categories are added to a so-called list of candidate ICF categories in this case, based on the patient's perspective. Then another preparatory study is a systematic literature review, and I won't go into the details of how to do that. Researchers know what systematic literature reviews are. It's done, the next process is done in a similar way. The systematic literature review results, the concepts are identified, and those concepts are linked to the ICF using the established linking methodology. And then again, a frequency analysis is done, and the resulting categories are added to the list of candidate categories, in this case, based on the researcher's perspective. Then the other study is the expert survey, usually done web-based or online. And this is a survey of experts preferably from all 6 WHO world regions, and that is also multidisciplinary. The expert survey results or the answers are analyzed, and the concepts of functioning and disability are identified, and those are again linked to the ICF. Again, a frequency analysis is done, and all the resulting categories I added to the list of candidate categories, in this case, based on the health professionals or the expert's perspective. And the last preparatory study is called the clinical multi-centered study. And this is a little different from the other preparatory studies in that here an existing tool called the ICF checklist, which can be found on the ICF page of the WHO website. And we use we call extended ICF checklist because we expand this existing ICF checklist based on the specifics of the health condition for which an ICF core set is being developed. And also you can use added data from patient records or perhaps a healthcare tool or a data collection tool. And again, a frequency analysis is done. And the resulting categories are added to the candidate category list. Then all of the results or the candidate category list are used as the starting point for a consensus process. As you can see here, I will explain a little bit more in detail when I introduce to you the ICF core sets for children and youth with cerebral palsy. So the ICF core sets and the process for developing ICF core sets and how to use ICF core sets was described in a manual or in a book, ICF core sets manual for clinical practice. It's currently in its second edition. The first edition was published in 2012 and it's now available, and an accompanying web-based tool, documentation tool is available here under www.icfcoresets.org. You can also find the link on the WHO website on the ICF page. And this tool enables you to search or select specific ICF core sets. You can combine ICF core sets if more than one health condition is present, and you can rate using the qualifiers and create a profile as you see here for that particular person. There are over, I think 39 ICF core sets available right now. And here you can see the list covering multiple health conditions from neurological to cardiopulmonary to musculoskeletal to different health conditions from hearing loss, vertigo, and of course we have created core sets for children and youth with cerebral palsy and adults with cerebral palsy. I will introduce to you the children and youth version, and Suzie will introduce the version for adults with cerebral palsy. So I'll move on to the ICF core sets for children and youth with cerebral palsy. Unfortunately, Dr. Veronica Chiariti, who led the project back in 2011 to 2013, is not available today. So I'm introducing the core sets on her behalf and her team. She is currently an adjunct associate professor at the University of Victoria at the Division of Medical Sciences, but at the time she was a PhD student at the University of British Columbia in the Department of Pediatrics, and this project was supported by the Children and Youth with Disabilities Society, and we also supported her work from the ICF research branch. At the time, we were part of the German Collaborating Center of the WHO Family of International Classifications, and the final or the first version of the ICF core sets were developed in June 2013 at Sunny Hill Health Center for Children. And as you can see here in the pictures, we have over 20 participants, experts, multi-professional across almost all WHO health regions, including two people from India, Dr. Anjan Bhattacharya from Kolkata, and Dr. Vipul Shah from Lucknow, India. The project was all the different preparatory studies and also the results of the International Consensus Conference were published in various publications, as you can see here. So you can look those up if you're interested. And the ICF core set for children and youth with cerebral palsy used the ICF Children and Youth version, which was published in 2007, rather than the reference classification ICF. And the ICF CY has the same organization. It's structured like the ICF, and it's pretty much the ICF reference classification with additional codes that specify specific characteristics of children and youth. So it has additional categories, altogether 1,685 categories, and has modified and expanded descriptions to account for the developmental process of children and youth, and the inclusion and exclusion criteria have also been modified. The reasons that the project team decided to use the ICF-CY is logical. It accounts for the developmental trajectory of children and youth. It recognizes also that a person's profile of functioning may change at different ages, especially when they're young, from birth to 18 years of age or even older, depending on the health condition. And that delays in mastering a skill, that does not always mean that there are structural or permanent disorders. It can develop over time. It can improve, perhaps also diminish over time. The objective of the ICF core set project for children and youth with CP was to develop ICF core sets for children and youth with cerebral palsy, ages 0 to 18 years of age. And the method followed the established ICF core set development process that I showed you before in a modified way because we're looking at different ages, and the age spectrum is quite wide, so that way they decided to change it slightly. Is there a question? The preparatory studies also was modified slightly. It did include the systematic literature review, the expert survey, also the qualitative study with interviews with children and adolescents with CP and their caregivers. But what was different is instead of using an extended ICF checklist, this project decided to do a retrospective chart review of the children who were in a tertiary rehabilitation center. And they looked at specifically the clinical assessments of the children ages 0 to 18 years of age to examine and to study the clinical encounters in an interdisciplinary assessment. But the results of all of these preparatory studies were, as normally done, put into a list of ICF categories that served as candidate categories for the international consensus process. Altogether, 216 categories were included in this candidate category list, 63 from body functions, 25 from body structures, 82 from activities and participation, and 46 from the environmental factors components. And of course, no personal factors, because there are no personal factor categories in the ICF right now. Also, the international consensus conference process was modified. The first part, developing the comprehensive ICF core set, was... Hello? I hear traffic noise. Can you please mute? Thank you. So the first part of the consensus process is the same as normally done, which comprises alternating working groups and plenary sessions to develop the comprehensive ICF core sets. And for that, we looked at each ICF category separately and discussed it, and then the participants decided whether to include the ICF core sets or the ICF specific ICF category in the comprehensive core set or not. In the second part, the categories of the comprehensive set that the participants decided to include were looked at in detail and were decided to include in the brief ICF core sets. The group decided to develop one brief common ICF core set and three different brief ICF core sets that are age specific. One brief ICF core set for children and youth below 6 years of age, one for the ages 6 to 4 or less than 6 to 13, and the last brief core set was from 14 to 18 years of age. So altogether, there were 5 ICF core sets that were developed for children and youth with cerebral palsy. In terms of the results, the comprehensive ICF core set comprises of 135 ICF categories, which cover all the components of the ICF except for personal factors. So there are 34 body functions, 7 body structures, 58 activity and participation categories, and 36 environmental factors. The brief common set comprises of 25 categories. The brief ICF core set for children and youth below 6 years of age comprises 31 categories. The age-specific brief set for the ages 16 to 13 comprises 35 categories, and the brief set between 14 and 8 of children 14 and 18 years of age comprises 37 categories. Dr. Chiariti, with her team, developed an ICF educational e-tool, which is an online tool. It's free. You can go to it and you can just enter in Google or another platform, ICF educational e-tool, and you will come to this. It will introduce the ICF core sets, the process of developing the ICF core sets, and also it includes different case studies that you can look at, go through, and it'll tell you how to use the ICF core sets for children and youth with cerebral palsy with these case studies and how to apply it in daily practice. There are also other implementation projects that have been conducted, for example, in Brazil, Malawi, Poland, and Russia. And the one in Brazil was the most published. As you can see here, the ICF core sets for children and youth with cerebral palsy has been used to guide the description of functioning disability in children affected by congenital Zika virus. And in Malawi, it's been used to guide service provision and community-based rehabilitation programs, and in Poland and Russia, in rehabilitation centers. If you want to know more about the implementation of the ICF core sets for children and youth with cerebral palsy, there's a publication introducing the global initiatives that promote functioning by using these ICF core sets. And with that, I'd like to thank you, and I will answer your questions at the end of the webinar.
Thank you very much, Mellisa, for this very lucid presentation. Moving on, we are collecting all the questions, and I request all the participants to post their queries in the chat box, and we will certainly address them at the end of the all the series of lectures. May I now invite Suzie Noten to begin her talk, and I would like to introduce Suzie Noten. Suzie is working in the Department of Rehabilitation Medicine in Netherlands, And she has worked extensively in developing the ICF course sets for adults with CP. And she has worked as researcher at the University of Antwerp, Belgium. And the research focused on factors that influence mobility, pain, functioning, and disease prognosis in patients with health condition. But she started her PhD at Department of Rehabilitation Medicine at Erasmus University Medical Center, Rotterdam. And her PhD involved actually the development of ICF courses for adults with cerebral palsy. So we are very pleased to have you here, Suzie, and to learn from you. Thank you for being with us, and please start your lecture.
Okay, thank you for the introduction. Can you all hear me well?
Yeah, we can hear you very well.
Okay, thank you. Well, I'm very pleased to give my presentation today, and I will focus on the development of the ICF course sets for adults with cerebral palsy. So due to some advances in healthcare, I think the majority of people with CP are now adults. So 75% of people with CP are adults. And but what we see is that the main focus of research in healthcare is still on children. But I think the good thing is that there is a changing perspective towards considering CP as a lifelong condition. So also there's an increase in focus on adults with CP. So I think that's why it's very important to also develop an ICF course for adults with CP. There's a premature decline in functioning in adults. For example, there's a deterioration in their walking function, pain and fatigue increases, and also other health issues can come up, such as depressions. And what we also see is that children and youth grow into adult roles, of course. Some things like employment become more important, independent living. So I think this course set can very well complement the ICF course set for children and youth with CP. So here are the steps that we've taken. So I think Mellisa explained them already very well. So there's 4 preparatory studies: the qualitative study, systematic literature review, expert survey, and then the empirical cross-sectional study. The results of all these 4 studies are included in a consensus process, and that leads to the first version of the ICF course for adults with CP. And now we're in phase 2, so I think the next step is going to be the testing and the validation of this course set. So I'll start by introducing the 4 preparatory studies. And I'd like to start with a qualitative study. I'm very happy to say that this study is recently accepted for publication, so hopefully you can find it online soon. So the aim of this study was to investigate the perspective of adults with CP on functioning and disability. And this study was performed in the Netherlands. So we recruited participants from Dutch rehabilitation centers and the patient organization CP Netherlands. We performed focus group discussions, 6 in total for adults with CP without intellectual disabilities. And we also performed individual interviews for persons with intellectual disability or with their caregivers. We of course wanted to do focus group discussions with these people as well, but they had a strong preference for individual interviews and not sharing their experiences in a group. So that's why we decided for individual interviews. And the results were all linked to the ICF categories. What we saw is that a broad range of difficulties were reported by adults with CP. Common problems that were seen in body functions were emotional functions, pain, of course, the muscle tone. And then for adults with CP, they also mentioned problems in their mental functions. For activities and participation, I think the main chapter that was mentioned was mobility, including fine hand use, hand and arm use, and also recreation and leisure was an important issue that was mentioned. And then also a lot of environmental factors were mentioned. So for example, products for mobility like wheelchairs or walkers, and also the healthcare services and support of, for example, family or other people. Then the next preparatory study is the systematic literature review. The aim of this study was to identify research studies on functioning and disability in adults with CP. So we reviewed the literature, and we were trying to find studies published between 2000 and 2017. And we extracted outcome measurement instruments. And these were again linked to the ICF categories. So this is what we found. So we included 189 studies in the final analysis, and 156 common outcome measures were identified. So I think this is a lot of outcome measures to measure outcomes of functioning in adults with CP. So I think this emphasizes the importance of a standardization of the functioning in adults with CP. And I think this graph is very promising. What you see here is that the number of studies published between 2000 and 2017. And what you see is that there is a large increase in number of studies published on adults with CP. So I'm very happy to see this, the number of studies going up. We again find a very broad range of ICF categories. Activities and participation were very frequently studied, even more than body functions and body structures. Frequent domains in the ICF component of activities and participation were mobility, also employment and self-care. And then again, body functions that were commonly found were pain and neuromusculoskeletal and movement-related functions. The third one was the expert survey. This is the publication of it. And the goal of this study was to investigate opinions of international experts on functioning and disability in adults with CP. So we performed an online expert survey of 6 questions addressing functioning and disability in adults with CP. And those were linked to ICF categories. So we included 126 experts from 32 countries. So representing all 6 WHO regions. And again, there was a broad diversity of categories, many body functions such as pain, fatigue, muscle tone, and also different activities and participation, which I think were the same as for the systematic literature review. And then also very interesting in this study was that there were many environmental factors reported. Then the last one is our clinical study. So the manuscript is submitted. And the goal of this study was to identify common problems as well as facilitative and hindering factors in adults with CP in a clinical setting from an international perspective. So this study was performed internationally. We included adults with CP with and without intellectual disability, who visited the healthcare center in the last 3 years. And we performed these studies in 4 different countries, so the Netherlands, Sweden, Thailand, and the United States. And we used the ICF checklist 2.1a, which Mellisa just explained, and we adjusted this checklist slightly because to make it more specific for adults with CP. A very broad range of problems was identified in the studies. The prevalence of problems was very high. And the difficulties in activities and participation were most frequent, especially in the adults with intellectual disability. And I think very a good finding is that for the environmental factors, they were either scored as a facilitator or a barrier. And I have to say that most items were scored as facilitator and less often as a barrier. So I think that's positive. So this is the summary of all 4 preparatory studies. So this was the input for the consensus process. So all results were combined, and this resulted in a list of candidate categories, including 48 body functions, 9 body structures, 56 activities and participation, and 41 environmental factors. Our manuscript is ready for submission, so hopefully you can find that online in a few months. We invited 25 experts from 15 countries, and all WHO regions were present, and also 2 persons from India were present. So I'm very happy to have you also on board on this consensus process. So there were a broad range of professional backgrounds, and we also included adults with CP as well as parents of adults with CP, because we think that their perspective is also very valuable in this process. So this is what it kind of looked like. So all the candidate categories were presented, and the participant had to vote if they want to include or exclude the category. So the input were the 154 ICF categories. And our consensus process was unique in its form because of the COVID-19 pandemic. It was not possible, of course, to organize a conference. So this was actually the first consensus process that was performed online. And that resulted in a comprehensive and a brief ICF course set for adults with CP. Because of the online process, we had to adapt a little bit because, well, it was very time consuming, of course, to go through all the steps in the original consensus process. So we had a few less working group sessions and plenary sessions. But in the first week, we started with a plenary session, and after that, the participants were divided into working groups, and they had to decide and discuss all the categories in the candidate list. So that was the first voting round, and then after that, there was another plenary session, and participants could discuss some ambiguous categories, and then eventually that led to the comprehensive ICF course set. And then that was the input for the brief set. So from the comprehensive course set, participants could select items that should be included in the brief set. So we asked them to rank the top 10 ICF categories in the first round, and then we gave them some feedback, and then we asked them to do the ranking again. So for the comprehensive ICF course set, 120 ICF categories were included. A lot of activities and participation, and 33 body functions, 8 body structures, 50 activities and participation, and 29 environmental factors. And then for the brief set, we decided for a cutoff of 27% of the number of categories in the comprehensive ICF course set. This was the same as for children and youth. So 27% of the categories from the comprehensive course set were included in their brief set. So we decided to follow that. So eventually 33 categories were included. Here is the overview of categories that are included in this brief set. So I think for the body functions, you see a lot of mental functions, also sensation of pain. And of course, the neuromusculoskeletal functions are very well presented. in the body functions, but also in body structures. I think a very diverse presentation of activities and participation, and also some important environmental factors such as products more mobility, support of family, and also health services. If you compare these to the core sets for children and youth, I think Mellisa already showed you this. So they developed 1 comprehensive and 3 brief core sets, and the methodology was, I think, overall quite similar, but they of course used the children and youth version of the ICF to do the coding. That resulted in 8 categories in their core set that are from the CY, so those could not be included in our core set. So if we compare our core sets, we see that 98 categories are the same, and then some categories are unique for adults, which I think are quite obvious. For example, higher education, employment, political life, some things that become more important when you become an adult. And then some things were unique for children. So for example, the preschool education. If we compare the brief sets, then we see important issues to teenagers, of course, included in the core sets for youth between 14 and 18. And then, of course, some important issues to adults, like making decisions, carrying out daily routine, doing groceries, things like that. So I think although the basis is the same, so we have a very solid basis, we definitely see the added value of the courses for adults with CP. So I'm very happy that we have developed this ICF courses for adults with CP, and this can in the future support the systematic assessment, standardized data collection, and making it much easier to compare our data. So the next step will be a focus on how to measure it, and of course validate the core sets in various social, cultural, and economic contexts worldwide. Some information on our next steps. So we are working together with the American Academy for CP and Developmental Medicine. Their Lifespan Care Committee is willing to support the implementation of these ICF core sets. I'm very happy with that. And then there's also a special interest group on adults and aging, and they're also interested in collaborating and implementing this core set. So I would like to thank you all, and it was a real pleasure to give this presentation today. And if there are any questions, please let us know.
Thank you very much, Suzie. Meenakshi, Girish here. That was an excellent talk, and there are a lot of questions coming in, and we are collecting the questions. But before we address the questions to you, I invite Mellisa to tell us again specifically about ICF brief course set for cerebral palsy in children. Is that right? In children. Thank you, Mellisa.
In terms of some more specifics than what I've already introduced, or? Hello?
Yeah, we can hear you.
Okay. Are you asking me to expand on I just shared my slides of the brief ICF courses. You want me to expand on that? Because the brief ICF course sets I introduced briefly, very briefly in my presentation. So as I mentioned, Dr. Chiariti and her team developed 5 ICF core sets, which does include a brief common set, which comprises of 25 categories, and 3 age-specific brief sets for below 6 years of age, 6 to 13 years of age, and 14 to 18 years of age. Are there any specific questions about these brief ICF core sets?
There are some questions, not specifically to ICF corsets with CP, but would you like to take the questions now, or would you like
Yes.
to? Okay. So there was a question from, actually this is a generic question from Dr. Sunanda Kohli. She's a developmental pediatrician from Delhi. And she has a comment that ICF codes used to be considered complete only when it is accompanied with qualifiers. Is it so?
That's what's been published by WHO, and that's what also says that in the ICF. But if you recall, I mean, ICF is about 20 years old now, and since then there have been many developments and many applications of the ICF. Different people, different organizations, different countries use the ICF in different ways. Some use the ICF qualifiers, which is introduced by WHO in the ICF book, but WHO clearly says this is just a proposal. You can use different scales. Some groups, for example, in Taiwan, the government decided to use the ICF as a basis for reforming their disability evaluation system, disability evaluation and decision about disability eligibility based on the ICF. And they use a very different scaling system than the ICF qualifiers. There have been a lot of concerns about the ICF qualifiers, that there's lacking research, which is true, but there is more and more research on the use of the ICF qualifiers. There are some groups, for example, in China for COVID-19, a group developed an ICF-based tool to assess COVID patients and survivors using the qualifiers and using the generic 30 categories. So there are different ways to use it.
Thank you, Mellisa. Another question is from a very senior and very experienced developmental specialist in India, Dr. Shashikala. She's from Bangalore. And her question is, there are no categories in personal component of the ICF. And is concerned because she feels that it is so, can we not have a general list of categories in personal components so that it helps in interventions, especially psychosocial interventions?
I actually saw that on the chat, and so I prepared a slide for that. Do you see my my page? So here there is some conflicts with regards to personal factors, because I mean, one reason why personal factors have not yet been classified in the ICF due to concerns that it could be used incorrectly for declining, for example, disability to persons because of different reasons, personal factor reasons. And there's also the questions, how do we differentiate between personal factors and what you see here, temperament and personality functions? There are codes already in the ICF, B126, and the respective third level categories for temperament and personality functions. So for such aspects of functioning, there are already codes. For example, extroversion, conscientiousness, agreeableness, openness to experience, optimism, trustworthiness. Those are some aspects that can be considered personal functions. There are also, in terms of emotional functions, there are also codes under B152 for emotional functions. There are also personal factors classification proposals that have been made for to WHO, but they have yet to decide on any of these. The two main ones were published by my colleague or ex-colleague now, Sylvia Guy and her team. And you can see here on the left side, it comprises of several categories. It was also set up similar to the ICF structure and codes. Here it covers personal history, biography, social demographic facts, feelings, thoughts and beliefs, motives, etc. And on the right side, there's another personal factors classification that had been proposed by a group in Germany led by Dr. Grothkamp, and they're actually using this in some organizations. There's similarities between those two proposals, but there are some major differences as well. In Germany, there's a working group looking at personal factors, considering these two different proposals. So there are some classifications out there on personal factors. And as I mentioned, the ICF does include some aspects that can be considered personal factors in as already. I hope that answers the question.
Yeah, I think that's a very good explanation to the question. I have one question from a very senior neonatologist from Calcutta, Dr. Sandeep Samanta. Actually, he runs one of the busiest OPDs in developmental pediatrics. His question is, he deals with a lot of neonates. So are there any specific ICF codes for babies 0 to 18 months? How do we describe their functioning when they have not achieved functions like sitting and, you know, the function that are most commonly described in the body functions categories?
Was there an example that I can, because I opened up the ICF-CY and then I can look to see what could be an example, because as I mentioned, there are over 230 additional categories in the ICF Children and Youth version that that address specific specifications of the developmental process and of children and youth. So depending on what it is, what the issue is, there could be a specific code for the particular age group. For example, the ICF-CY core set version for CP, there are 8 categories that are only in the ICF-CY that are not included, that are not part of the ICF reference classification. So depending on what this the specific aspect of functioning, there may be a particular code for babies who younger than toddler age.
Okay, he's not given any specific instance, but I think what you referred to, the documents, he should get answer to his question by referring to those particular course sets. Is that right?
Yes, probably it's best to contact Dr. Shiariti because she's a development pediatrician, so she could probably answer that best.
Yeah, there is a question from Dr. Shabina Ahmed. She is the chairperson of a neurodevelopmental chapter of the Indian Academy of Pediatrics in India. And her observation is in personal factors. She doesn't see any category for learning style, choice, and interest, which is so important specifically in growing children. So any comments on that?
Yes, so it's learning style and what was the other one? Learning style and interests?
Yeah.
Yes. In terms of interests, the 2 proposals that I mentioned from Sylvie Guy and Sabine Rothkamp do include interests in there. So those particular personal factors classifications do cover those. However, the ICF itself does not have any codes for interests or beliefs of some sort, but the interests and desires are reflected in the actual, what the person is actually doing in terms of activities and participation. For example, I mentioned the case of in Girish. He was interested in collecting toy cars and also liked food, good food. So those things can be used in text form, can be described in text form, as I had indicated on the example, but it could also be reflected, for example, in the category of D920, recreation and leisure. And under recreation and leisure, there are specific categories for socializing, for arts and crafts, and all of those things, sports, that can be reflected in there. But that's true, they're not, or coping learning styles. There are, as to my recollection, there are ICF categories in the activities and participation under chapter 1, acquiring skills. For example, learning to read. There's D140, learning to read, and under that there are third level categories, as well as under learning to write, again, third level categories that can reflect that. But it's not necessarily learning styles, but how they're actually acquiring skills. So it's really the manifestation in the person's action, engaging in the particular action that's reflected.
Thank you so much. Mellisa, there's a lot of questions coming in, but I would particularly put forth a question which was asked by my colleague, Dr. Maria Levin. She's also a developmental pediatrician in Bangalore. And her question is something which is very close to my heart as well. She says that while ICF helps assess function very comprehensively and in great detail, and it also helps plan intervention, can this be used to measure impact or outcome of intervention, both at individual level and at community level?
Yes and no, because it depends on the scale. Because if you talk to measurement people, measurement experts, they say using, for example, ordinal scales like ICF qualifiers is not sufficient to really indicate the impact of the ICF categories of functioning, of interventions before and after an intervention. My institute is actually working together with the Swiss, what do you call it? The Swiss accident insurance, and they have 2 rehabilitation clinics serving adults with different types of injuries and health conditions. And we're looking exactly at that, the impact of rehabilitation on functioning of these people. So we're using RASH methodology. So it's changing the ordinal scale into a interval scale that can most accurately assess the impact of interventions using the outcome of functioning, using the generic 30 set. So different aspects of functioning with the 30 categories, and assessing it at admission and at discharge. And hopefully also post-discharge, you can take a look at different time points. So you can use the ICF categories as outcomes depending on the scaling.
So related to this, I just wanted to tell you that we read Veronica Chiarity's article on assessment of each categories. I think one of the articles, she's given a table in which she's given a list of assessment measures that can be applied for a particular function. Now, it doesn't seem to be a very practical and feasible list for a health professional to use in a busy clinic. So we need to look at assessment measures to use ICF for this purpose, for the purpose of measuring the impact of intervention. We need to have assessment measures which are not very lengthy, which are easy to use, and which can easily be applied in the shortest possible time. So has any work being done on that? And related to this, there's a question by Dr. Arnab Seal. He is the chairman of the European Academy of Cerebral Palsy, and he has been mentoring us quite a lot in our activities related to ICF in India. And his question is, are the currently available ICF course sets for children and adults, valid for different contexts and cultures? Can they be used in India without additional validation studies? So I just want to quickly add, there are two questions in this question. I mean, one is I wanted to ask you whether we need to validate the existing course sets in India before we start using them. Second, are there any work going on finding the most feasible and relevant assessment measures for a particular course set?
Yeah, that's a several multifactorial question. There, as I introduced earlier, there are generic sets, one containing 7 categories and one containing 30 categories. So they can be used independent of health condition, independent of setting, independent of country where it is culturally independent. They are not yet being used on a systematic basis. And of course, as researchers, as academicians, we say we want, if we have some sort of tool, we want to make sure it's valid for the different settings. So of course we would support validation studies, but I know clinicians, they don't really care. As most clinicians who are not dealing with research, they don't really care. They just want to have something they can use. Okay, I see you're raising your hand. On a daily basis, they want to make make their life easier and their work easier, that they have something that they can use. So you can use these ICF courses, but just to make sure that people understand, the ICF course sets are just a list of categories. They are sort of like a checklist, so you can say that you don't forget anything, that you make sure you cover everything. But even if you have a list of categories that are generic, you can still add categories depending on your particular person. I mentioned earlier this ICF-based e-learning tool, and an e-learning tool, the ICF electronic tool, that you can take a look at that. It's www.icf/core/sets.org. It's in my presentation, so you can send it out to everybody. And you can take a look at that. You can choose different core sets. You cannot delete any categories, but you can add categories to it depending on your particular case. But this electronic tool is not, you cannot save on our database. You have to save it on your computer itself. And there are ICF-based tools that have been developed that are shortened versions of existing course sets, like for vertigo, for vocational rehabilitation. Yeah, so hopefully that answers the question.
So you were talking about all these tools that are available for people who are interested in knowing more about ICF and its categories and components. So you also said that you used to conduct workshops in different parts of the world. So is that different from what is already available on the website? What are your workshops? What do they cover? Anything other than, if somebody was interested in attending such
Yeah. Yes, it's because our workshop was actually the template for the e-learning tool that's on the WHO, that's being hosted by WHO, because we actually developed the e-learning tool for them, and they expanded it. Basically, the workshop that we conduct is more extensive. It goes more into detail. There's exercises, individual and group exercises, so you really get to know the ICF quite well. And there's it's set up in modules. So we have modules for ICF application and rehabilitation management, ICF and disability evaluation, ICF. We also go very deeply into the linking methodology, and the ICF qualifiers. So that's what our workshop's all about.
Is there any workshop in the near future which anybody who's interested in can apply and be part of?
Yes, 25th through the 26th of March, we are conducting a 2-day virtual workshop. Each day consists of 3.5 hours via Zoom. It costs 250 francs, which is about 235 euros, and the equivalent of whatever it is in the different countries. So it's international, it's held in English, and it's the first time we're doing a virtual workshop. So hopefully it'll work out well. Usually it's a face-to-face. But I was also in India in 2013 in Kerala and conducted a workshop for different clinicians.
Obviously, a lot of us missed that. So we will certainly look forward to any future workshops that will be held. So we'll look out for details of this on the ICF Research Branch website.
Yes, it's on the homepage. Yes.
Yeah. A question to Suzie from Dr. Shashikala, and she would like to know when will your ICF courses for adults be published in DMCN or wherever? I mean, what is the timeline you think we can?
So for the consensus process paper, we still have to submit it. So I'm afraid that will still need some time before that is published. But for the qualitative study, it is, well, I think it's soon coming, but if it is online, I can, of course, update you, send you an email about it.
Okay. There are some questions still coming in, and yeah, if right, there was a question, I couldn't understand it, but maybe Mellisa would be able to decode this question. Dr. Sanket from Mumbai, he wants to know what are the categories for environmental accessibility?
Yes, there are several. One, E150, 155, that's regarding access to public and private buildings. There's one land development. So those are the for physical accessibility. That would be. In terms of educational accessibility, accessibility to different services, there are different environmental factors. I think it's in the E5, each fifth of the chapter 5, there are different categories for that.
Okay. So basically the each environment component has all the chapters related to any kind of accessibility to like accessibility to all kinds of environmental support, right? So,
it doesn't, yeah, these are all the environmental supports, for example, products and technology, products, substances, medication, food. So they're not all about accessibility, but there are different environmental factors that can be facilitative or pose a barrier to functioning, including people, persons, immediate family, could be employers, or the health system, lack of health services. Those are all represented there. But you will not find accessibility, the word accessibility, in the ICF. And I saw a question regarding the UN Convention for the Rights of Persons with Disability. In the UN Convention on the Rights of Persons with Disability, the ICF is not specifically mentioned, but there are attempts by different countries to use the ICF to monitor the UN Convention. For example, that was also the impetus for the reform of the disability evaluation system in Taiwan, in Poland as well. And in Germany, for example, they have a law on participation that rehabilitation facilities need to address participation as an outcome using ICF, or ICF, that has to be ICF based. They don't necessarily have to use categories, but it has to be ICF based.
Okay, Mellisa, I'm sure everybody has a lot of questions after listening to such comprehensive lectures on the topic of ICF. And I just would like to ask you, if the questions keep coming into us later on, can we just communicate with you from IACP to get more clarifications in future? Would that be all right?
Sure. Yeah.
So thank you so much. And also I want to confess that in the past 1 or 2 months, some of us, including myself, have been involved in teaching about ICF to a few people, to our colleagues, and compare, when we compare ourselves to what you did today, we really know that, I mean, we are novices and you are right there when it comes to explaining about ICF. Thank you so much, Suzie, and thank you so much, Mellisa, for making this sound so simple. I would like to ask Jasmeet to do the concluding honors for this webinar.
Thank you so much, Dr. Mellisa and Dr. Suzie. I invite Dr. Malika Arjun for a vote of thanks.
Thank you very much. This is actually lunch time in India. As Dr. Ashok Johari said, also chatted with us that this is a lunch time. But Mellisa and Suzie offered us a wonderful knowledge feast so that we all had a very sumptuous knowledge for today's lunch. And I thank Professor Ashok Johari sir for postponing all his surgeries and works to today's working day to attend this wonderful, excellent webinar. And Dr. Rangasai is a former director of NIHH, shown a lot of interest to attend this workshop webinar. I thank him on behalf of IACP. May I request Dr. Ashish Ghosh say vote of thanks on behalf of IACP. Dr. Ashish Ghosh. Ashish Ghosh.
Sir, please unmute yourself. Unmute yourself, Ashish. Yeah. Can you please unmute Ashish?
Yes. Good afternoon. Thank you, Dr. Mallikarjun sir, for letting me give you a vote of thanks. But actually, before giving vote of thanks, let me confess that I am spellbound with the lectures by Dr. Mellisa Selb and Dr. Noten. In the last year, in 2019, we all met in Bangalore to discuss this ICF issue and how this can be implemented in India. And since then we have been working on, Dr. Meenakshi Girish has taken the lead, and a lot of experts in India and abroad, and one from Bangladesh, they're also working. We are also trying to work out some code sets for three NDTs like cerebral palsy, autism spectrum disorder, and ADHD. So with your lectures, lots of things we have come to know, and we hope that we will be benefited out of your lecture. And I would call this as a lifetime opportunity to listen to this kind of lectures, and that too on our web. So I thank you. I mean, from the core of my heart, I thank you all, and the officials of Indian Academy of Cerebral Palsy who have made this possible to give this opportunity for us to listen to you all. Thank you, sir. Thank you, Professor Dr. Shakti Das and Dr. Meenakshi, for very ably moderated the session. Thank you, Dr. Meenakshi, for your nice moderation of this entire session. And thank you everyone who has you know delayed their lunch, because this is Indian lunch time, and patiently lend their ear to this discussions. Thank everyone, and I wish that this kind of discussions will continue, and we will be able to hear from you. And once we start working, we will have some problems, barriers, I'm sure we will. And whenever there is a problem, we will try to contact you for possible solutions. Thank you so much.
Thank you, Dr. Ashish, for kind words, and thank you, Dr. Mellisa and Susan, again on behalf of Indian Academy of Cerebral Palsy. Especially thank Dr. Jasmeet Arora and Vinod for extending their kind support to make this webinar flawless streaming. Thank you very much. Thank you, one and all.